Topic is spinal anesthesia. The specific learning objectives for spinal anesthesia are: what is the anatomy related with spinal anesthesia, what are the indications of spinal anesthesia, describe techniques of spinal anesthesia, also describe physiology after giving spinal anesthesia. And we will be discussing contraindications and complications of spinal anesthesia. These are the SOLs related with spinal anesthesia. So what is anesthesia? Spinal anesthesia, also called as spinal block, subarachnoid block, intradural block or intrathecal block. It's a form of neuraxial regional anesthesia involving the injection of a local anesthetic like bupivacaine, lignocaine or an opioid like fentanyl, buprenorphine into the subarachnoid space, that is in the CSF, and it is generally given through a fine spinal needle. So what are the indications? When anesthetist gives the spinal anesthesia, for which type of surgeries they like to give spinal anesthesia, especially in those cases or in those surgeries which are infraumbilical surgeries like orthopedic surgeries, fracture tibia, fracture femur or hip surgeries. Like general surgery, spinal anesthesia can be given for hernia, hydrocele or fistula in ano. For gynecological surgery like abdominal surgeries or vaginal hysterectomy and many more. And in obstetric, as we all know, cesarean section are usually done under spinal anesthesia. Also urological surgeries can be done under the spinal anesthesia. So what is the anatomy related with spinal anesthesia? We all know that there are 33 to 34 vertebral spines in our body, in human body, and when they are stacked together, that forms a spinal canal. There are 7 cervical vertebral spines, 12 thoracic, 5 lumbar, 5 sacral, and 4 to 5 are coccyx. And this all form a spinal canal. And what is the boundary of spinal canal is foramen magnum to sacral hiatus. And the extent of spinal cord is from foramen magnum to L1. And beyond L1, the spinal cord continues as a cauda equina. The spinal cord extends to L1 and continues as a final terminal ending at the first segment of the coccyx. There are 31 pairs of spinal nerves carry the motor and sensory information. Like cervical 8 sensory nerves, thoracic sensory nerves are 12, lumbar are 5 sensory nerves, sacral 5 and coccygeal 1. So when we give a spinal anesthesia, what are the structures to be pierced? It is from the skin to the inner side. First is the skin and subcutaneous tissue, then supraspinous ligament, interspinous ligament. You can see in the diagram, supraspinous ligament, first is the skin and subcutaneous fat, then supraspinous ligament, then interspinous ligament, then is the ligamentum flavum, and then dura and subarachnoid layer. And here we go inside the subarachnoid space which we call as intrathecal space also. It contains the phylum terminal, cauda equina and CSF. In the CSF we inject the drug. So what about CSF? Total volume between the brain and spinal cord of the CSF is 120 to 150 ml. It is secreted by the ependymal cells of the choroid plexus within the ventricular system at a rate of 30 ml per hour. Entire volume of the CSF is replaced once every 3 to 4 hours. As we all know, the circulation of CSF, it is secreted in the choroid plexus, goes to lateral ventricles, from where it goes to cerebral ventricles, then through foramen mondre, it comes in third ventricle, then through aqueduct of sylvus, it comes in a fourth ventricle, and through foramen luschke and magnendi, it comes in a subarachnoid space. And characteristic of CSF is specific gravity is very important when we give a spinal anesthesia to the patient. Specific gravity of CSF is usually from 1.003 to 1.009. Volume is 130 to 150 ml. And volume around the spinal cord is around 20 to 30 ml. So whenever we give spinal anesthesia to the patient, the pre-op evaluation, as discussed in the earlier lecture by Dr. Yogesh, is must. Preparation in the regional anesthesia and PSC are exactly as same as the general anesthesia. You have to remember that regional anesthesia can turn into general anesthesia in matter of second. And in addition to the above, a careful examination of the back needs to be done to look for the spinal deformities, scars or a presence of inflammation or infection. And we usually do spinal anesthesia with the spinal needles. There are 2 types of spinal needles, dura cutting and dura separating. Dura cutting are most famous is Quinky, and with the dura cutting needles, the chances of post-dural puncture headache are more. But with the dura separating like Sprotte or Whitcare, which is very famous, the chances of PDPH is less. An important point about spinal anesthesia, when we perform spinal anesthesia at L3, L4, L4, L5 or L5, S1, we are injecting into cauda equina and not anywhere near the actual spinal cord. So there is no danger of damaging spinal cord itself. So what are the important landmarks whenever we do a spinal anesthesia? The most two important landmarks are spinous processes like L4, L5, L3 and iliac crest. We have to palpate the highest points on the iliac crest and draw an imaginary line. And this line usually passes through the L4. We usually prefer the interspace L4, L5. However, L3, L4 can be preferred. There are three main approaches for spinal anesthesia: midline approach, paramedian approach, what we call as a lateral, and very rarely we do lumbosacral approach, that is called as a Taylor approach. And three positions in which we can give spinal is sitting position, lateral, prone. Very rarely we give in prone position. Now the technique of spinal anesthesia. Whenever we give a spinal anesthesia, we have to ensure the total asepsis. Like we have to scrub our hands and lower forearms for 3 minutes and rinse with the water. And then we have to wear the gloves and gowns also. And large area over the lumbosacral area has to be scrubbed between the lumbosacral spine and the iliac crest. See, this is the sitting position. You can appreciate the back. Back is just, the patient has made it rounded and extended outwards, and neck is flexed. Someone has to hold the patient from front so that patient should not fall. Pillow is also given to stabilize the patient. This is lateral position. You can see the neck is flexed, knees, hips, both are flexed and bring to the abdomen, and the patient is lying like a baby. Okay, here you can appreciate L4 level, okay, iliac crest. From both an imaginary line is passed from highest point of the iliac crest, which is passing through the L4. The cord ends at L1. So, here the needle is in the midline approach. You can see if we pass the needle in between the interspinous process, in a straight direction, it will go in a intrathecal space. But if you angulate it in an upward and downward direction, it may hit the spinous process. So this is the technique of a midline approach. As we advance the needle, especially when we feel the pop, like give off, pull out the stylet and look for spinal flow. If it is there, connect the syringe containing local anesthetic. Initially aspirate only enough to create a swill in a local anesthetic to show that getting free flow of fluid. The swill is from mixing two fluids of a different densities. Now you have to hold the hand against the back and stabilize the needle and connect the syringe containing local anesthetic and inject the drug slowly. So this is the schematic representation of injecting the local anesthetic through the spinal needle in intrathecal space. This is paramedian approach. This is called as lateral approach. The difference between lateral and midline in its insertion site of the needle and angle of approach. The skin wheel is just has to place 1 to 2 centimeter lateral to the chosen interspace. The needle is directed medially and cephalad at an angle of 15 to 20 degree, pointing towards the midline. The lateral technique is better to use in a patient with limited flexion of back. It bypasses the calcified ligaments encountered in elderly patients. The lumbosacral approach, Taylor approach, is very rarely used. It is through the L5S1. Now, when we are injected a drug in an intrathecal space, so what this local anesthetic is going to do with the body? So it's a physiology. Local anesthetics in subarachnoid space blocks the sensory, autonomic and motor impulses. It interacts with the anterior and posterior spinal nerve roots and dorsal root ganglion as the drug passes through the CSF in upward direction. Blocking anterior nerve root fibers blocks the motor and autonomic transmission, and blocking of the posterior nerve root fibers block the somatic and visceral impulses. So, how now the level of the spread? Once you have given the local anesthetic in intrathecal space, it has to spread. But what will be the level of the spread? It will depend on the many other factors. So, let's see the distribution of local anesthetic solution in CSF, and it is dependent on the baricity of the solution, contour of the spinal cord, position of the patient during and in first few minutes after the placement of drug into the subarachnoid space, and dose of the local anesthetic injected. There are other contributing factors also. So what is varicity? There are three different mixtures of local anesthetic what we use: hyperbaric solutions, hypobaric and isobaric. CSF has a varicity of 1.003 to 1.008 at a normal body temperature. So hyperbaric solutions are made by adding glucose in amount sufficient to increase the density of local anesthetics above the CSF. Lidocaine 5%, bupivacaine 0.5%. Nowadays, even the ropivacaine and leobupivacaine are also coming in a hyperbaric solution. They are usually premixed with the dextrose and come in a hyperbaric solution. We rarely use isobaric or hypobaric solution for an intrathecal injection. Hyperbaric solutions being heavier than CSF, the solution settles in most dependent aspect of the subarachnoid space, and this is determined by the position of the patient. When supine, the solution tends to gravitate to the thoracic kyphosis, and the level achieved is usually T6. See, in this diagram you can see the drug is injected at L4, L5 level, and since we are using hyperbaric drug, it has settled down towards the gravity in a thoracic kyphosis and even in a sacral nerve roots, and we could get the T6 level. But if you keep the patient in a sitting position, and if a patient is allowed to stay in sitting for some period of time, this will allow the production of low sensory levels of anesthesia. It will typically produce a saddle block because it numbs the area that would be in a contact with the saddle when riding a horse. The position of the patient during and shortly after the injection of local anesthetic is another primary determinant of the level of block. Supine level usually gives T6, 7 level, and if you keep the patient supine with the head slightly down, it will push the block up to T4, T5. And if you keep the patient supine and head up slightly, it will give a block around T9, T10 to T11. So this is how the position affects the level of block. Other factors are pregnancy, ascites, large abdominal or pelvic tumor, as this lowers the amount of CSF in a cord. Okay. Then age-related decrease in CSF volume may push the level higher than the expected in elderly. So there are contraindications of neuraxial blockage. These contraindications are divided into absolute contraindications and relative. Absolute contraindications is patient's refusal, that I don't want spinal anesthesia. And if there is an infection at local site, or patient is having coagulation disturbances, then this is the absolute contraindications. But there are many relative contraindications. Anesthesiologist has to take a wise decision when these relative contraindications are present. Like diseases of the nervous system, if you consider CNS, in case of CNS, brain tumor, syphilis, meningitis. Then in case of spinal cord, poliomyelitis or multiple sclerosis. In case of hypovolemia, shock, hemorrhagic, may be septic or a severe anemia. Again, the spinal anesthesia is relatively contraindicated. And whenever patient is having coronary artery disease or a valvular heart disease or the cardiac decompensation, again the spinal anesthesia is contraindicated. Then anatomical deformities like scoliosis, post-traumatic vertebral injury or a metastatic tumors in a vertebral column. In uncooperative patient or mentally disturbed patient or patient on anticoagulant therapy, the spinal anesthesia is relatively contraindicated. Although the spinal anesthesia is very safe procedure, the mortality or morbidity is very rare and very low, but there are certain complications, especially intraoperatively. Intraoperatively, hypotension and bradycardia are very common, but can be managed if the doctors or anesthetists are vigilant. But you have to be vigilant wherever spinal anesthesia is given for hypotension and bradycardia. In case of high spinal or a total spinal, nausea, vomiting, difficulty in phonation, restlessness, anxiety, respiratory paralysis and cardiac arrest. Hence the readiness for CPR has to be there. And local anesthetic anaphylaxis is very, very, very rare. Other complications which are post-operatively common is post-spinal headache, which is easily manageable. And uncommon are urinary retention, nerve injury, nerve root damage. If given at a higher level, then spinal cord damage may be there, intraspinal or epidural hematoma, meningitis, transient neurological symptom, cauda equina syndrome, paraplegia, spinal cord ischemia, anterior spinal artery syndrome. They are very rare. also local anesthetic toxicity or epidural abscess. So these are the references for this spinal anesthesia lecture. Thank you very much.